Good evening. Thanks for joining us for our educational webinar on Lapiplasty 3D bunion correction. I really appreciate everybody joining. My name is Kara Lyons. I'm Director of Patient Outreach for Treace Medical Concepts. Treace is a company who has patented the Lapiplasty procedure, and we manufacture its instrumentation and implants. This is the fourth webinar in our monthly series, and our goal here tonight is to provide you with quality information, because we know that making a decision about surgery is not a decision that you're undertaking lightly. And I've got just a couple quick housekeeping items to get out of the way so we can get right into the presentation by our surgeon speaker tonight, who is Dr. Robert Taylor out of Frisco, Texas. First of all, you are listening and joining the webinar in what's called mute mode, but you can still ask questions. You can do that throughout the presentation by clicking the questions tab in your control bar, and you can type them into us. We'll be answering questions that are sprinkled throughout the presentation tonight, and then we'll be doing a question and answer session at the end of the presentation. If you're a note taker and you're listening, you inadvertently miss something, we'll be offering this presentation archive link. So look for that as a follow-up item from us in the next couple days. And lastly, I know that you're going to really enjoy our surgeon speaker, Dr. Taylor. But if you're attending this webinar and you live outside the Dallas metropolitan area, you can actually find locally trained Lapiplasty surgeons in your own area. And you can do that by visiting our patient education website, which is called alignmytoe.com. There's a really prominent Find a Doctor button at the top of the homepage, and that is searchable by zip code. Okay, now that I've got all those housekeeping items out of the way, I'd like to introduce tonight's speaker. Tonight's surgeon speaker is Dr. Robert Taylor. Dr. Taylor is a paid consultant of Treace Medical and has a long list of credentials. His qualifications and experience are extensive. However, since he is one of the most humble doctors I've met, Dr. Taylor's only allowing me to give a few nuggets from his bio here. He's board certified in foot and ankle surgery. He's an author and lecturer, and he's been a past president of the Texas Podiatric Medical Association. He's not only a user of the Lapiplasty system, but he's also a clinical investigator for our Lapiplasty Align 3D clinical study. And speaking of the Align clinical study, we are also joined tonight by Treace representative Shana Zink. Shana is our Vice President of Clinical Affairs, and she's responsible for the post-market clinical study of Lapiplasty 3D bunion correction. Shana will follow Dr. Taylor tonight and will discuss some key study details, including how you may be considered for participation in the study, if you'd like. I'll return to moderate a question and answer session in the end, but now I turn it over to Dr. Taylor.
Good evening. I appreciate all of you that have come online to talk about this Lapiplasty system, this exciting system about the correction of bunions. Just to kind of get some things, talk about some things and get some things out of the way, some basic information about the Lapiplasty. It's been FDA cleared since 2015, so it's not an investigational device. It's a patented procedure. And as Kara said earlier, it's manufactured by Treace Medical Concepts. To do this procedure, it requires advanced training. And as she referred to, if you were interested in this procedure and you want to find a doctor in your area that was trained to do it, you can go to alignmytoe.com/doctor, and there's a great search tool there to show you the doctors that have been trained to do this procedure. It is covered by most insurances and Medicare, and costs do vary based on each individual insurance, so you want to check with your provider to see if it is how it's handled in that particular area. You know, before we dive in, you know, we live in a day and age of incredible advancements in the field of medicine and particularly surgery. And there can be a tendency sometimes to just assume that because surgery is so advanced, we gloss over the fact that all procedures and surgeries, regardless of how straightforward they appear, and regardless of how experienced the surgeon is, there's inherent risks with surgery, and results can vary from one patient to another. With the procedure we're going to be discussing tonight, potential risks are those that are similar to any type of orthopedic or podiatric type procedure, and those are things like infection, discomfort from the implant that is used to fixate the bones. Sometimes implants can loosen and have to be removed down the road. A loss of correction with a non-union or a malunion. What that means, a non-union means the bones don't heal like they were intended to, or a malunion is they only partially heal or heal in a position that they weren't intended to. And if any of these things occur, you'll have a conversation with your surgeon about what the next step is. And sometimes that next step is going back and fixing the problem. So I just want to make sure that everybody understands we are talking about a surgical procedure, and all surgical procedures inherently have risks. I think I might not have moved my slide there. Are we good now? Here we go. All right. Sorry about that. My technical skills are lacking a little bit. So is a bunion affecting your quality of life? I would imagine that everybody that's on this webinar either has a bunion or knows someone who has a bunion. And when you ask about the quality of life, I think that's somewhat of a vague term. When I ask a patient this question, has the bunion affected your quality of life? I'm really asking about two things. Is there any pain associated with your bunion, or have you made any changes in the things that you do or the shoes that you wear because of your bunion? And examples of this would be, because sometimes they're subtle and people don't realize how many changes they've made, but they don't go on trips where they know they're going to have to stand and walk a lot, like those old weekend shopping trips with their girlfriends. Or they only wear Uggs in the winter now instead of their winter boots, not because Uggs are in and cute, but because their winter boots really hurt their feet. Or shoes that normally were very comfortable now are problematic. So those are things that, in my mind, tell me that the bunion has affected your quality of life. So what is a bunion? I get a lot of patients that tell me, first of all, they hate that word, a bunion. The medical term for a bunion is actually hallux valgus. And hallux is the Latin term for the great toe, and valgus is the position of the toe. You'll also see bunions described as hallux abductovalgus. And what we're looking at, most people refer to, is this bump, this knot that they notice on the inside of their foot. And a lot of patients will even tell me, how do I know I have a bunion? And obviously, for some people, it's pretty evident, but in others, they're either told you have a bunion and they didn't even know they had one. But we're going to get into more in-depth conversation as we go, talking about bunions are more than a bump. There's a misconception out there that bunions are simply this knot or bump at the base of the big toe, with occasionally the big toe drifting over. And this is a picture showing 5 different feet with bunions, and you can obviously see that there's a significant difference in all these feet that we show here. And we'll get into what correlates with the severity of a bunion. So why do bunions hurt? Besides the structural problem, we know from biomechanical studies that The way our foot is designed, we put a tremendous amount of pressure through our big toe joint. And anytime the big toe joint is altered, particularly with a bunion, it will cause a significant amount of pain. So a lot of people present to a doctor with pain in the area. Actually, you can even have pain not only just in the joint, but also in other parts of your foot, because once the great toe joint stops functioning as it should, it's going to refer pressure and forces to other parts of the foot that aren't designed to pick that force up. A lot of patients will get swelling in their foot, particularly if they've been on their feet for long periods of time. Pressure, numbness is a very common thing I'll see, where folks will tell me they'll have numbness when they wear certain shoes, and then after a while, even when they take that shoe off, they still experience some numbness on the inside of their foot or their great toe. And then obviously, shoes have a lot to do with it. But we'll talk about this in a second. Shoes aren't the cause of it, and that's a misconception out there, but it definitely influences how your bunion feels. My goal tonight is, I tell this to my patients when they come to see me, is my goal tonight is that everybody on this call becomes an expert on bunions. And there's two things that we know for a fact about bunions. One, there's a genetic predisposition, and later we'll talk about there's a progressive nature about bunions. But when we say a genetic predisposition, what that means is somebody in your biological tree, parents, grandparents, and even if you're adopted and don't know your family history, somebody had this genetic predisposition that causes the foot to have a biomechanical imbalance to occur. And we'll show you some x-rays and show you what that looks like. Shoes don't cause bunions, but they definitely will aggravate a bunion and accelerate it a lot further than it typically would be. You don't have to be a foot doctor to look at this picture and realize that if you wear that shoe, you're going to be putting some relatively abnormal forces on different parts of the foot. And I look at this picture and it kind of makes me chuckle, because when I trained, I remember some of my attendings walking into rooms and telling ladies, go home and throw away all of your high heel shoes and your pointed toe shoes. And I would laugh inside. I wouldn't dare laugh outside in front of them, but I would laugh inside because I knew the reality of that happening wasn't realistic. If you want to wear a high heel shoe for a few hours, church, wedding, party, anything like that, I think that's appropriate. Now, it may be uncomfortable, and if you come out of the shoe and soon thereafter those symptoms resolve, my opinion is there's not a problem with that. But if you want to wear a shoe that's on this picture all day, every day, we need to have a conversation, because that is problematic. Other things that affect how much a bunion bothers people is their job and the types of shoes and activities those jobs have. And it's pretty obvious if you have a job where it's a casual atmosphere and it's a desk job, you may not have as much problems with your bunion as somebody who has to wear business wear or is known to be on their feet all day doing things that cause a lot of pressure on the foot. So shoes and activities and occupations definitely have an impact on how much bunions bother the people. And the second thing, remember I talked about there's two things we know about bunions. They're genetic and they're progressive. And that basically means they will get worse as you get older. Now, it varies from person to person how fast they progress and to the extent that they progress. But a surgeon can safely say when you have a bunion, it is progressive, and over time, it will get worse. So how do you treat bunions? I tell patients there's two ways. One second here, sorry about this. For some reason hey Kara, can you, oh there we go, sorry about that. There's two ways you treat bunions. There's conservative treatment and there's surgical treatment. Conservative treatment, I tell patients, is whatever we can do to make your bunion and your foot more comfortable. And those are things like spacers, pads, splints, orthotics. Something that this slide doesn't show is anti-inflammatories, Tylenol, aspirin, things of that nature. And I tell patients, if I can do something to make your bunion and your foot hurt less, that's a good thing. But you have to understand we are treating the symptoms of your bunion, not your bunion. You still will have a bunion, and it will progress over time. As far as the pain is concerned, a lot of times it has to do with what stage the bunion is in. In early stages, cushions, pads, anti-inflammatories, and things of that nature can give you some significant relief from the pain. But eventually, my experience is it gets to a point that no cushions, pads, splints, shoe changes really get rid of all the pain that the patient's experiencing. And there are patients that until they have surgical correction to address the root cause of the bunion, they will always have these symptoms. So what happens if you don't treat a bunion? As we talked about, it is progressive. And what that means is as the bunion starts to progress, and we'll show you some x-rays here later in the talk, and the great toe starts to move over, a series of things start to occur. One of which is the toes tend to draw. We call these hammer toes. They tend to draw and sometimes even overlap. Another very common thing is patients start to experience pain in other parts of their foot, not just in their bunion, but in the ball of their foot, and sometimes the entire foot can actually start to bother people. Here are some other frequently asked questions doctors that treat bunions, particularly with the Lapiplasty, are asked. Is there an age limit? The Lapiplasty system is actually FDA cleared for ages 12 and higher. Now, there's some specific things in younger patients you want to look at, but that's just to give you an idea of some of the younger patients that actually will have symptomatic bunions. Is a bunion so severe it can't be treated? The simple answer to that is no, but there might be cases where it's so severe that a Lapiplasty might not be your best choice. And there are procedures such as fusions and things that might actually give you a better outcome. But to answer that question in its simplest form, no, there's not a bunion that's so severe that can't be treated. And then what if you had bunion surgery in the past and you have a bunion again? I'll tell you that this is probably the area where those of us that do Lapiplasties, our patients are sometimes the happiest. Those patients that had bunion surgery and the surgery either failed or they had a reoccurrence of a bunion. So you absolutely can have revisional surgery with this system if you've had bunion surgery in the past. This is a really important slide to understand. As I told you, I want you to be experts on bunions. We talked about their genetic, we talked about their progressive. The next thing you need to understand is bunions are more than a bump. A lot of people think it's a bump. I've actually had patients tell me they've had other physicians tell them it was a calcium deposit or a bony buildup. Bunions are not a bony buildup that can be shaved down. They are a structural problem that results in an unstable joint in the metatarsal, which is the long bone behind the big toe. And there's a series of events that happens as that first metatarsal starts to move because of that unstable joint. So be careful about anyone telling you all you need to do is have the bone shaved off. It might look good to you, and we have some examples of that later, but you are going to have problems again if somebody talks to you about simply shaving down the bump. So what does a bunion look like on X-ray? Here's an X-ray of what a normal foot looks like, a left foot, and here's an X-ray of what a foot with a bunion looks like on the right. I would draw your attention to the big toe on both of those x-rays. On the left, where that's a normal foot, there's a somewhat linear alignment of the big toe and the metatarsal behind it. And I wish I could have a pointer, but on the metatarsal, you can see, I don't know if you can see my mouse, but there's these two bones, and those are called sesamoids, and those have a lot to do with the alignment of the first metatarsal. And when you look at this picture on the right of a bunion, you can clearly see that first metatarsal is moved away from the second metatarsal, and there's clearly a alteration in the position of those two little bones as far as what you see on a normal x-ray. And you can see that there kind of highlighted in red. There's been several studies that talk about the alignment and the position of a bunion, and I don't want to get too technical into the minutia of angles and things, but I do think it's really important that you understand why this system is unique and why so many bunions fail or people have reoccurrence after a previous procedure. Bunions, 80%, 87% of the time, according to this article in Foot and Ankle International, which is an international orthopedic journal, they had numbers as high as 87% of bunions are misaligned in 3 dimensions. And I want you to picture, if you hold your arm out in front of you and palm down, I want to kind of show you what 3 dimensions is. So say your arm is supposed to be straight out in front of you, palm down. If you move your arm out away from center, that's 1 dimension. If you lift your arm, that's another dimension. And if you rotate your arm where now your palm is, say, up or sideways, that's 3 dimensions. And so you can see in your mind's eye, if I need to get my arm in the position back to where it was before, I need to move it in all 3 directions to get it back where it's supposed to go. The problem is, in the past, our surgeries were able to move them in 1 or 2 directions, so we could get it back in front where it's supposed to be, and we could move it up and down, but the rotation of taking like the hand going sideways or up to back down has always been the challenge and the thing that was missed. And again, this system allows the surgeon to correct it in all 3 planes, which is very important. A real good word picture is like what you see here in the slide with the Leaning Tower of Pisa. There's movement, there's an unstable foundation, there's an unstable joint called the first metatarsal cuneiform joint, which allows that first metatarsal to swing out. So that's 1 dimension. The second problem is, we see with bunions, is the bone not only swings out, like you remember my arm analogy, it goes up, which is the 2nd dimension. And then there's the rotation, which I talked about. If your palm is down and you rotate at any degree one way or another, there are 3 problems with how that first metatarsal is rotated. And this is, I love this picture with a car. If the wheels are out of alignment, you can move them one way or another, back and forth, but unless they're brought into the proper orientation, that car is not going to run properly. So let's talk about traditional bunion surgery. What we've done for many years is make a cut in the bone called an osteotomy. And as I said earlier, you're able to move that bone sometimes 1 direction, depending on the cut, sometimes 2 direction, but traditional bunion surgery lacked 3-dimensional correction. And the contemporary thoughts now are that is why a lot of bunion surgeries have failed in the past, is 1, a lack of appreciation of all 3 planes, and number 2, an inability to correct all 3 planes. So let's look at this Leaning Tower of Pisa model again. One of the common ways we fix bunions, and anyone that's been doing bunion surgery for a long time will tell you they've done many surgeries this way. But one of the common ways is you shave the bump down, and then the next thing is you make a cut in the bone, and you shift over the piece of the bone, typically in the head, that you cut. And you can see again, using our Leaning Tower of Pisa picture, that just doesn't look right. I mean, you look at that and you go, that's not the way you should fix the Leaning Tower of Pisa. You should go back to the foundation, the base where the problem is. But this is the way so many surgeons for years have been fixing bunions. And again, we're taking a bone that is in the wrong position and we're cutting it and we're making it crooked to try to make it appear straight. And we haven't addressed the unstable joint. Now, your foot may look okay, and you look at this picture of the foot to the left of the X-ray. That looks like a foot that doesn't have a bunion. It's had a successful bunion surgery, but the X-ray tells us just from the position of that joint that more likely than not, this particular foot, that bone will continue to move in the direction it did before to create the bunion. As the cliche goes, when you fix a bunion that way, it's like putting lipstick on a pig. Here's another interesting bit of facts that we get from some of the contemporary research in foot and ankle surgery. We know now that if a bunion has three-dimensional deformity and all three dimensions aren't addressed surgically, you are 12 times more likely to have reoccurrence of that bunion. We also know from contemporary research that 1 in 3 patients that have had two-dimensional bunion surgery aren't happy with it. And I will tell you that more likely than not, it was because it was a three-dimensional bunion deformity that had a two-dimensional correction. And then there are studies that show as high as 70% of patients who've had osteotomies, again, 2D bunion surgeries, can have reoccurrence of the bunion over time. And I don't know about you, but those aren't percentages and odds that would make me feel comfortable moving forward with a procedure if a doctor told me that there's an up to 70% chance I might have this problem again. I want a better fix. I want a better mousetrap. And that brings us kind of into our discussion about the system while we're here tonight. The Lapiplasty 3D bunion correction. The motto is fix it right the first time. And that's the way I want to be treated, and I'm sure that's the way you want to be treated. And so when we look at what this looks like on X-ray, if you look back kind of where you can see plates and screws on that X-ray, that is where the problem is primarily addressed, at the foundation of the problem. And one of the neat things about this system is this. Before the bone is cut, before the bone is fixated, the deformity is corrected. The patented instrumentation of this system allows us to do this. As you can see from that picture and the bone model there, this is a device called a positioner. And so when we're in surgery, we release the soft tissues that are necessary to be released, and we literally correct the deformity before we do anything else. And we're able to look at the foot under X-ray, under fluoroscopy, and make sure everything is lined up where we want it before we even make any cuts in the bone. And when we do this, we know and we are confident that we have corrected that bunion appropriately. And this is a picture that shows after the correction, the fixation that is used to secure those bones so that they heal. And another exciting thing about it is the technology of those plates. This is science fiction stuff. This is above my pay grade. But the guys who put this stuff together, it's titanium technology. The other thing that we've known for a long time, the position of plates, the amount of plates can have a dramatic impact on the stability and the strength of these constructs. So you take this patented titanium technology and you add the proper orientation and the additional plate, and it's really, really revolutionized some of the things that we can expect from these bunion surgeries. So let's take a look at some X-rays and see what you can expect to see after a Lapiplasty bunionectomy. Here's a preoperative x-ray on the right, and again, you can see the bump where the big toe joins. As your eye goes towards the bottom of the slide, you can see the joint where it's unstable. And then as you go over to the Lapiplasty picture, the post-op picture, that alignment, that linear alignment, that collinear alignment of the toes and all the metatarsals, that's what you want. That's the position that you want. And you can see the screws and the plates. And again, I know you're not radiologists or foot and ankle surgeons, but when I look at that x-ray, I also notice the nice healing that's occurred in that unstable joint. So that's what we expect to see when we see an x-ray after a Lapiplasty. Let's take a look now of what we see when we look at the traditional 2D surgery. Again, the bone has been shifted over, and the outside of the foot appears that the bunion has been corrected. But again, draw your eye down towards the bottom of the slide, towards the unstable joint. And I tell people, you don't have to be a radiologist or foot and ankle surgeon to see that angle that's there of that joint that should be relatively, you want it relatively horizontal, but that's an unstable joint that's going to continue to move outward. And again, back to the Lapiplasty, look how that joint that's fused is somewhat horizontal and perpendicular with the plane of that first metatarsal. That's the kind of correction that you want when you're having procedures done to correct a bunion. A new thing right now, not just in foot surgery, is minimal incision surgery. And I will tell you, I think minimal incision surgery in various parts of the body absolutely has some indications. But what you don't want to do is pick a surgery by how small the incision is. I'm regularly consulted with patients who ask me about, how big is the scar, and they're going to do surgery with this doctor because this doctor's incision is a lot smaller than the other doctor's incision. Scar management is important, don't get me wrong, but do not pick a procedure because a doctor tells you he can do it with very small stab incisions. If you're going to have a reoccurrence or a failure, you will be kicking yourself on picking a surgery simply because the doctor told you the incisions are quite small. And again, you don't have to be a foot and ankle surgeon or a radiologist to look at the x-ray on the left and see the orientation of the metatarsal as it's moving away from the other metatarsals, and the head of the bone that's cut over and fixated in place with these two large screws versus what the Lapiplasty looks like on the x-ray on the right. Here's an interesting slide that shows what a traditional Lapidus is, and some people may ask, where does the word Lapiplasty come from? And it's kind of a blending of the procedure that's done when you fuse the unstable joint was called a Lapidus. And so this is a traditional Lapidus x-ray here with a large plate and screws. But again, you can see the surgeon may have had the right mindset of, I need to address the problematic joint, but without proper instrumentation, without the proper cut, it almost looks as if the unstable joint was fixated in its improper position. So that's not an uncommon thing you'll see, even with a doctor who knows where the problem is, if it's not adequately corrected intraoperatively. Here's a normal foot, and this right here gives us a great picture of the restoration of normal anatomy that we expect to see when a Lapiplasty is performed. If you take away in your mind's eye the fixation on the x-ray on the right, that's a normal foot. But that was a foot that had a really bad bunion, and look how similar it looks to an x-ray of a foot of a person who doesn't have a bunion. The metatarsal phalangeal joint is still free to move, and on the unstable joint that's present when a person has a bunion is now stabilized. So why pick the Lapiplasty bunionectomy procedure? Hopefully I've kind of talked about this and we'll talk about it more. It addresses the root problem. It has the ability to correct in all three planes. And one thing I haven't talked about, which we're going to talk about in a little bit, it gets you back on your feet quickly in a walking boot, and it's intended to permanently secure the unstable joint. And this isn't just the words of me who've done several, or a couple doctors who've done this procedure. There are peer-reviewed published articles that validate some of these claims. One article by Ray in Foot and Ankle International, which is an international orthopedic journal that deals with foot and ankle surgery, had a 97% success rate with maintaining the 3D correction. That's the kind of percentage I want a doctor to give me when I'm thinking about having a surgery. Let's take a look now on what these feet look like kind of before and after surgery. And again, this isn't intended to say this is what you can have. As I talked about earlier, results vary. There's always inherent potential risks and complications, but this helps to get a picture of what typical bunions look like and what a foot typically looks like after it's had a Lapiplasty bunionectomy. And so the picture on the left is before surgery, and the picture on the right is 12 weeks after surgery. And what I'll tell you is this: that picture on the right, that foot's going to continue to look better. And the reason I know it's going to continue to look better is 12 weeks after any surgery, foot, knee, back, neck, if anybody's had surgery, you know there's still a lot of healing going on. So if that foot looks that good 12 weeks after surgery, I tell my patients all the time, it's going to continue to improve because there's still some swelling. You may not have any pain. There's still some swelling there that will take a while for it to completely go out. But that's a picture of what we typically see. Here's another picture of a right foot. On the left, before bunion surgery. On the right, 12 weeks after surgery. And not to be redundant, that foot on the right is going to actually look better. That scar is going to remodel some more. Some of that swelling is going to continue to improve, but it gives you kind of a picture of what you can expect after bunion surgery. And I think this is the final kind of clinical example I have. Again, before surgery, this one's a little bit longer, 16 weeks after surgery. You take away the faint scars on there and you look down at that foot, you'd never know that person had a bad bunion just 4 months prior to that surgery. So some exciting things that you can expect when you deal with a surgeon who's trained to do this type of procedure. What about recovery? I know for a fact that recovery after bunion surgery has been a deal breaker for many, many people who've had bunions, because the typical recovery for this type of surgery where the unstable joint was fused was 6 weeks of completely off of your foot. And I would tell patients myself, there's no way I could take 6 weeks to stay off of my foot. So if I had a bunion in the past, I would have either had to live with it or I would have had to do one of those 2D corrections with a high risk of a bunion coming back or a poor result. But what you can expect typically with this Lapiplasty procedure is within days, and it varies from surgeon to surgeon, within days you're able to walk in a boot, in a surgical boot, and over the next 4 weeks you're walking in that boot. And typically at week 6 is when we get most patients out of the boot into a comfortable shoe. 4 to 6 months, and again, this varies from surgeon to surgeon, but about 4 to 6 months is when most doctors will release their patients from restrictions. My protocol is about 3 months. I allow patients to really start ramping things up, but it's safe to say within 4 to 6 months, most folks are returning to most activities that they want to without any restrictions. So let's walk through just the particulars, because I think it's important. I tell patients the surgery is the easy part. It's typically a day surgery, outpatient day surgery. What you have to wrap your brain around and what you have to expect is what are those first few days and weeks look like. So days 1 through 5, you have your surgery. Your doctor will give you a prescription for some pain medication. You'll be fitted with a boot. You'll have a dressing that's put on after surgery that you're asked to keep clean and dry. We will encourage you the first few days to keep your foot elevated. That helps with the swelling. It helps with the discomfort. We will ask you to rest and to ice. And again, you'll be given very specific written out guidelines in what you do. But the first few days, I tell my patients, get your Netflix out, get some magazines, get some books, buy some good food, and try to be a couch potato for a few days as best as you can. Aspirin, a lot of doctors will use as a way to reduce any risk of blood clots, especially if there's maybe a history of it, but that's surgeon specific as far as aspirin is concerned, or the use of an anti-inflammatory. The first post-op visit. This is typically the first about a week after surgery. For my patients, it's day 6. A lot of doctors call this the big reveal. You get to see what your foot looks like. Some patients are so excited. Some patients don't want to see their foot. You see them get a little clammy. They don't want to see anything, so you lay them back. But most people are really excited to see what their foot looks like. And even with bruising and swelling, there's often a dramatic difference in the appearance of the foot. So that 1 week visit, you get to see what your foot looks like. You'll get a new dry sterile dressing. You'll be asked still to ice and to rest your foot. Some doctors at this point will allow you to then start bathing and washing your foot. Some doctors will still ask you to keep it clean and dry for a few more days. But about this time, things start to get a whole lot easier. About the 2 to 2.5 week mark, you really turn the corner. I tell folks for the first couple weeks, you're recovering from surgery. Any surgery, that's the biggest whip of the surgery. The first couple weeks, you want to be resting, you want to be elevating your foot. But when you hit 2.5 weeks, you start to feel better. You still have some swelling and tingling in your foot, but you definitely can tell you feel better. You're washing your foot, which I know that sounds simple, but I can't tell you how many patients tell me when they're able to just wash their foot, it just feels better. You're doing some exercises that your surgeon is giving you for range of motion. Depending on how your surgeon closed your incision, this is the visit where sutures are removed. Sometimes, in my instance, I use subcuticular stitches, meaning the stitches are under the skin, so there's only 2 little stitches that need to be clipped. But week 2 is a big deal. You turn a corner just from a timeline perspective. Week 6 is another big rah-rah visit. That's when you get out of your boot and you get into a comfortable shoe. Most often that's a good supportive shoe, like an athletic shoe, but you get into a comfortable shoe. Driving, I didn't say this before at the week 2, and again, I'm going to tell you my take on this, and then what the standards are out there with a lot of different doctors. Some doctors, if you're having your right foot done, because you're in a boot for 6 weeks, they ask you to make arrangements not to drive for 6 weeks. And it's not because the act of driving is going to affect your healing. It's just simply not safe to drive with that big boot on. And if something were to happen, even if it wasn't your fault, it just doesn't look good if you're getting out of a car with this walking boot on. My protocol with the right foot is I give patients a post-operative shoe after the 2nd week to allow them to do very short driving, and when they get there, they put their boot on in the car before they do any kind of walking. So your surgeon may require 6 weeks. Some surgeons allow some driving at 2 weeks. You need to be prepared for the 6 weeks. I might be in the minority by allowing patients to drive at 2 weeks in a post-operative shoe. Again, not the boot, a post-operative shoe. You're continuing to do some elevation, some rest, some ice. At this point, a lot of doctors, if they're giving you the aspirin as a preventative, they'll stop it simply because now you're moving, things are flowing like they should, and so the risks really decrease. So a lot of times they'll have you discontinue your aspirin, and they'll start ramping up the exercises. Week 12 is another graduation. And at week 12, you really can now start wearing whatever shoes feel comfortable for you. A lot of times this is when patients will reintroduce their orthotics back into their shoe. I still tell my patients, if you're sitting down and can prop your foot up until this point, do it, because I think it helps with the swelling, and it helps reduce how much swelling you have. Ice is hit or miss for some people this far out. Some people, ice works better than pain medication and reduces swelling better than elevation and compression, while other people tell me, I don't really tell too much with ice. It's crucially important on the front end. When you get out to this point, I tell patients it can only help, but I leave it up to the patient at this point. But week 12 is a big, big mark as far as your activity level and the shoes that you wear. At 4 months post-op, you're probably like, are we done yet? And this graduation, I would say, is 3 to 4 months. And at that point, most doctors, unless there's something going on with your specific healing, most doctors are now going to allow you to do activities to tolerance. And that basically means if you can do it, you can do it. If you can wear it, you can wear it. Some folks are wearing compression hose to help control some residual swelling that's present, but it's not uncommon at this point, if a patient's doing well, the doctor will tell them, call me if you're having any problems. Otherwise, I'll see you in the community, or I'll see you in the grocery store, or something of that nature. We'll talk later about a study. For those of us that are participating in a study, we have some folks following up because we really want to start documenting how well these patients do after this procedure. And then you start getting back to the activities that you enjoy and the whole reason you underwent this type of procedure. Here are some more frequently asked questions. When can I expect to return to work? I answer this question by asking, what do you do, and how long can you afford to be out of work? And obviously, if a patient has a desk job where they literally are at a desk 8 hours a day, or they have the ability to work from home, which is a very common theme these days, they can get back to work really, really quickly. They can log in or be at a computer with their foot elevated. If, however, you work in a factory or construction, or you're a nurse that has 12-hour shifts, it's going to take you a little bit longer before you can get back to work safely. So it has really a lot to do with what you do. When will I be able to drive with my right foot? I talked to you about this earlier. You need to plan on it possibly being 6 weeks before you can drive, but some surgeons will allow you to drive earlier with an apparatus different than the boot, but only for driving. Is it possible to have both feet treated at the same time? Possible, but not recommended. I had a nurse today try to over and over to talk me into doing both of her feet at the same time. I accused her of trying some Jedi mind trick on me, and I kept reiterating to her, I am biased because I'm a foot and ankle surgeon, but I tell people, second to your eyes, your feet are extremely important to protect, and you don't want to make a decision purely for the sake of convenience that you'll regret for the rest of your life with every step that reminds you. I just had eye surgery a few weeks ago, and eye surgeons, they used to do bilateral or both eyes at the same time. Now they only do one at a time for that very reason. Get one eye done there, because if something happens, you have your good eye at least for a while before they do the other eye. The same thing with the feet. Get one foot treated, get it fixed, and then once you're stable and comfortable with that, come back and do the other. I know that results in 2 surgeries, but I promise you, it's the best thing to do. And again, I would be remiss if I don't keep hammering this home. As with any surgery, there's always inherent risks, and you need to understand that. And risks with any type of bone and joint surgery are things like infections, things like problems with the plates or the screws that were implanted. And obviously, we think we have a high rate of success, but regardless, there's always a risk of loss of correction. And as I defined earlier, a non-union meaning the bone not healing, or a malunion meaning the bone partially healing or healing in a position that we did not desire. And again, I tell my patients if any of these things occur, we're going to have a conversation, and that conversation might include the thought that we need to go back and fix this problem. Again, the likelihood of these things happening aren't high, but anytime you have surgery, you have to have an understanding that these are possibilities that could occur. So I'm going to now turn this over to Shayna, who has some things she wants to talk to you about a study that we're doing regarding this this procedure I just talked to you about. Shayna, I'm going to go ahead and turn it over to you.
Thank you, Dr. Taylor. Good evening, everyone, and I am happy to be here to share with you tonight information about the Align 3D study. And I'm also available to answer any questions you might have about the study and to help you understand how you may qualify to participate. Next slide, Dr. Taylor. If you do have a painful bunion and that bunion requires surgical correction, you may qualify to participate in the Align 3D study. This study is a post-market outcome study, which means that the Lapiplasty devices and procedures are being used in the study in the same manner as they're being used in practice every day. This study is collecting data on the immediate and the longer-term outcomes of the Lapiplasty procedure. Next slide. The Align 3D study is primarily being done to measure the rate of recurrence of a bunion at 24 months after the Lapiplasty procedure. As Dr. Taylor mentioned, we have other clinical data and that has been recently published in it did demonstrate that there is a low rate of recurrence at 13.5 months, and the rate of recurrence was demonstrated to be 3.2%. However, in this study, we are evaluating the recurrence further out at 24 months and up to 5 years post the procedure. In addition, this study is collecting data for other outcomes such as healing, improvement in pain, and quality of life, all with patients returning to early protected weight bearing in the surgical boot after the Lapiplasty procedure. Next slide. To qualify for the Align 3D study, you do need to be between the ages of 14 and 58 years old, and you must have a bunion that requires surgical correction. In this study, only outcomes after the Lapiplasty procedure are being studied. So if you do qualify for the study and agree to participate, you will undergo the Lapiplasty procedure in this study. You will need to be evaluated by a study surgeon to determine if you do qualify for the study. And even if you do not qualify for the study, you still may be a good candidate for the Lapiplasty procedure. During the study, data is going to be collected on your recovery and your results after the Lapiplasty procedure. You will be required to have x-rays taken of your foot at the post-op visit, and you will be asked to answer questions about your pain and your quality of life before and after the Lapiplasty procedure is completed. And this data is going to help Treace learn about your experience after the Lapiplasty procedure, including the long-term results on the correction of your bunion. Next slide. If you do qualify for the study, you may be compensated for your study-related time and travel. In order to learn more details about the study and whether you qualify for participation, you can contact one of the following study sites. Next. So there are 2 sites in Texas. One is UT Southwestern, and this is our lead investigator site, and also Dr. Robert Taylor, who is presenting tonight in Frisco, Texas, and I will give him a little bit of props for being one of our lead enrollers in the study. Next slide. We do have several other sites participating in the study, one in Colorado, Iowa, Missouri, and West Virginia. Next slide. A few frequently asked questions about the clinical study. One question we receive is the Lapiplasty procedure considered investigational? And Dr. Taylor has touched on this already. So even though we are running a clinical study, the answer is no. The Lapiplasty procedure itself is not investigational. The Lapiplasty procedure and devices are used in the study, as I said, as they are used by the surgeons in practice today. And while we are collecting data in a study setting, the procedures and devices, again, are used according to their label, and the Lapiplasty procedure is being done in the same manner whether you participate in the study or not. Another question is, do I have to be 14 to 58 years old to have the Lapiplasty procedure? For the Align 3D study, yes, you do need to be in that age range in order to participate. However, the procedure is cleared for ages 12 and above. So even if you do not qualify for the study, you may be a good candidate for the Lapiplasty procedure. However, this can only be determined by a surgeon. Another question is, are those the only doctors who perform the Lapiplasty procedure? The answer is no. These are the centers and the doctors that are participating in the Align 3D study. But there are many more doctors that perform the Lapiplasty procedure. And if you are looking for a Lapiplasty trained surgeon, please see alignmytoe.com/doctor to find a trained surgeon near you.
All right.
All right.
Kara, I think you've got some questions.
I do. Well, first of all, I want to thank you, Dr. Taylor and Shana, for volunteering your time this evening to present to us. We do have some questions coming in, and we are open to receive more if there are more. You can ask your question by clicking on the Questions tab and typing in your question. I'll start out by directing one of the first questions to Shana. Shana, we have a question about insurance. Is the Lapiplasty procedure covered by insurance and or Medicare?
So yes, insurance and Medicare typically cover bunionectomy and joint fusion procedures that utilize the Lapiplasty system when these procedures are considered medically necessary. So you will need to see your doctor to determine that your bunionectomy and or joint fusion is necessary utilizing the Lapiplasty system, and then your doctor can reach out to your insurer to determine your specific level of coverage.
All right. We have some questions that pertain to other conditions of the foot and whether or not they could be a candidate for a Lapiplasty. One of them is, what about having a bunion on the outside of the foot near the base of the small toe? Is that the same as having one on the big toe?
The bunion, the bump on the outside of the foot, we call those Taylor's bunions, no relation to me, or a bunionette, and those are very different than the bunion on the great toe joint. Those are sometimes treated with osteotomies, sometimes with smoothing down the bump. Sometimes that bump is actually a cyst or a bursa, and it's not very much bone that's swollen there. So while they might look the same in appearance on the outside of the foot, they are two different things. But they can be corrected simultaneously if you have them. If you have a true bunion on your big toe joint and that bump on the outside of your foot, it's not uncommon that folks have both of those addressed surgically at the same time.
Just to clarify, is the Lapiplasty procedure used on that Taylor's bunion, or is it only used on the larger toe?
No, the Lapiplasty is only indicated for the great toe deformity.
So what if someone already has some overlapping toes? Sometimes that's referred to as hammer toes.
So as a bunion progresses, it's not if you're going to get hammer toes, it's when you're going to get hammer toes. And how I determine if a person's going to not only need their bunion corrected with a Lapiplasty, but other procedures, is I try to reduce the deformity, get the big toe close as possible to where it's supposed to be, and then evaluate how flexible the toes are. Sometimes if you catch it early, those toes can relax and you really don't have to do anything to address them. But the longer they're pulling up and basically trying to get out of the way of the big toe moving over, the more rigid they become. And the more rigid they become, the more likely you're going to need a surgery on the toes or the joints behind them to correct that problem as well. So it's not uncommon with folks who've had bunions for some time that they also require an additional procedure on the second toe and sometimes even the third toe because the toes have drawn up as a result of the bunion.
Well, we have a question about comparing the Lapiplasty procedure with Lapidus.
So the Lapiplasty procedure is basically, in its truest sense, a type of Lapidus procedure. But the difference is it's a Lapidus type procedure that allows the surgeon to correct in all three planes. I want to make sure I'm clear about this. The Lapidus procedure has been around for many years, and basically it's the fusion of the first metatarsal cuneiform joint. But again, typically we were able to get correction there in one or maybe two planes. The Lapiplasty allows that Lapidus type procedure to be performed in all and corrected in all three planes, and the correction done before you even make your first cut. So there is a big difference. They're similar but different.
Okay. Somebody writes in and says, my doctor said because I have arthritis in my toe bunion, if I got the Lapiplasty surgery, I would also need traditional surgery to remove the arthritis. Is this correct? So would I need two surgeries?
I'm not sure what your doctor meant specifically by that, but I will tell you there are instances where if you've had a bunion that's been there long enough or severe enough, you will develop to some degree arthritis, and if it becomes severe, it can have an impact on the success of a procedure like a Lapiplasty. And there are instances where a patient has a very bad bunion but a lot of arthritis in the big toe joint, and there might be procedures that are more appropriate than doing the Lapiplasty. What you don't want to do is get a beautiful correction, meaning you get those bones aligned exactly like they're supposed to be, only for you to still have some problems simply because there was so much arthritis in the joint. So that doctor, again, I don't know who that doctor is or what they meant. I'm only speculating. They may have meant what I just said, or if they did the Lapiplasty, they were preparing you that if you had some discomfort in the joint, they might have to go back at a later time to basically clean out the joint or do something else in the joint.
Okay. Going back to the pictures of the before and after results, this person has a question. Will the position of the consecutive toes correct themselves as time goes on?
It depends on how much and how much they've drawn up and how flexible they are. And as I said, they will start to draw as a bunion develops. And if you correct the bunion early enough, I have seen toes that have started to draw, relax, and resume their normal position. But again, that's a time-sensitive issue. The longer the toes are adapting and compensating for the abnormal biomechanics of the bunion, the more likely you're going to need something done on the toes as well as the bunion. But yes, there are times where you correct the bunion and you also notice an improvement in the position of the toes, but you won't know that for sure until there's a proper and complete evaluation of the foot. And sometimes that's even done intraoperatively.
Okay, we have a couple study questions, so I'll shift gears and go back to Shayna for these. One question is, I'm 59 years old, so I can't do the study, but would I still be a possible candidate for the surgery?
Absolutely. As mentioned, the Lapiplasty procedure is cleared in ages 12 and above. The study is a smaller population with the age range of 14 to 58, but that does not mean you're not a good candidate for the Lapiplasty procedure.
How is someone evaluated to become part of the study?
So the evaluation for the study is, and Dr. Taylor may want to jump in as well, is in essence the same as your evaluation for the Lapiplasty procedure itself. First and foremost, you have to be a good candidate for the Lapiplasty procedure before you could be considered for the study. And the evaluation for the procedure would be the same as your evaluation to participate in the study.
Yeah, I would concur. You first have to be a candidate for a Lapiplasty, and then there are other things that we look at too. If there's certain comorbidities or illnesses that you might have, you still can have the Lapiplasty. You just might not be an appropriate candidate. Age, we talked about. Smoking, we're using that as an exclusion because we know that smoking has a significant impact on bone healing. And I'll give a little public health shout out to any of y'all that are listening that are smoking, please stop. But it's things like that. So first we determine if you're a candidate or not, and then there's some exclusion criteria that we go through with you to determine if you can be a candidate for the study.
One last question on the study, and then we'll switch gears back to the doctor. How am I reimbursed for clinical trial participation?
So the visits are reimbursed from your initial screening visit through the 5-year visit. The study is looking at outcomes for up to 5 years. So every time you complete a study visit, including the screening visit, you would be compensated for that visit procedure through the doctor's office.
All right, switching gears back to the doctor. If I do have to have both feet treated by surgery, how long should I wait or expect to wait between the surgeries?
That's a very common question that I get, and my answer is a minimum of 6 to 8 weeks. And I tell people 8 weeks, and my reasoning for that is for 6 weeks you're in a boot, allowing that foot to heal, and at 6 weeks we allow you to get out of the boot into a regular shoe. And I just think it's very valuable to give that foot a couple weeks getting used to being in a regular shoe before now all of a sudden you're kind of overloading it, compensating for a boot being on the other surgical side. So my preference is 8 weeks. There are some circumstances, whether it's job changes, insurance changes, whatever, that sometimes affects that. But if patients can give me 8 weeks, if they want both feet done and can give me 8 weeks between the two, that's my preference.
When you have the surgical procedure, are you put completely under for the procedure?
It's typically done with a general anesthetic, unless a general anesthetic is contraindicated. So if you have some kind of medical condition where the anesthesiologist feels that you're a not good candidate for general anesthetic, there are instances where it's done with a block or even what's called an IV sedation case. But I would tell you 99.9% of the time, it's a full general anesthetic. Whatever's the safest for the surgeon and the anesthesiologist and the patient to perform the surgery.
Okay. This person says, in addition to bunions on both feet, I have severe rolling arches. As a result, my legs are misaligned, resulting in lower back pain. Can the Lapiplasty procedure correct for the rolling arch be done at the same time?
Yes, in fact, I was at a conference or a little class last night with some surgeons that were learning this, and we had this conversation that a lot of times the bunion is only one of other problems that a person's foot may have. And rolling arches, I'm assuming you're talking about like flat feet or fallen arches is a common term. There are times that in order to have the outcome with the Lapiplasty that you desire, other things need to be addressed as well. And that would be a conversation that you would have with your surgeon. Sometimes they're all addressed at the same time. Sometimes the surgeon may prefer to stage them, correct some of those other problems you have with your feet, get you healed, then come back and correct the bunion with the Lapiplasty.
Another question comes in, does the Lapiplasty procedure affect the mobility of the foot?
So it initially does. You know, anytime you have surgery, you have scar tissue and swelling, and you'll notice your range of motion isn't as good. But then as those tissues heal, your range of motion should come back. And in fact, I've had patients who their range of motion after a Lapiplasty is better because of the realignment. And speaking of the study, that's one of the things we're looking at. What happens to the range of motion in a foot after it's had Lapiplasty? Like, what is the range of motion before surgery? What is it immediately after surgery? What is it 6 months, a year after surgery? The joint that we fuse, which is the first metatarsal cuneiform joint, is not a joint like a ball and socket joint or the big toe joint. It really has minimal, if any, motion there. So when that joint is fused, most people notice no difference in the range of motion in their foot. So that's something that you should not have to worry about, is what kind of effect it's going to have on your range of motion. And if it does have an effect, in my opinion, it's minimal, and it shouldn't affect your ability to do any kind of activities.
All right, this is a question about neuroma. So, is my bunion causing the painful neuroma on the bottom of my foot?
I couldn't tell you that your bunion is causing your neuroma, but what I can tell you is many patients with bunions can develop neuromas simply because the way your foot is designed, most of our pressure and weight should go through the great toe joint. When you have a bunion, a lot of that pressure, and we have studies ad nauseum that show pressure is then picked up in the ball of the foot, and increased pressure in the ball of the foot, either from the bottom or from side to side, is one of the more common causes of people developing a neuroma. So I can't tell you for sure that your bunion caused your neuroma. What I can tell you for sure is a bunion will definitely make a neuroma probably hurt worse than it normally would have, and more likely than not is being impacted by your bunion.
Okay, we have a couple questions about what to expect in terms of lengths of recovery time.
So just kind of a snapshot of what to expect is you'll have surgery on whatever the day of surgery is for the surgeon. It's a outpatient day surgery, which means you come in, you have the surgery, and you go home. For the first several days, we ask you, I tell people I want you to be a couch potato. And that basically means I want them on the couch, in a recliner, in a chair with an ottoman, keeping their foot elevated, icing, and just really kind of relaxing. At the first week after surgery, which is typically surgeons will see their patients anywhere from 4 to 7 days after the surgery, the first dressing change is performed. Typically, there's a second visit around 2 weeks after surgery, and then at 6 weeks after surgery, that's when you're allowed to get out of your boot. By 2 weeks after surgery, again, there's surgeon preference. Most, if not all surgeons, are encouraging their patients to be walking on the foot in the boot. The variance is in those first few days. Some surgeons want their patients walking on it right away. I'm in the camp that I just ask my patients to take it easy for that first week or so.
Okay. We have a couple questions around eligibility for the Lapiplasty surgery. What is the criteria to be eligible? Or, this is a little bit related, what condition makes a case medically necessary?
A bunion is medically necessary if, in my opinion, it's affecting your quality of life. And what I mean by that, and that's a question I ask my patients because it's a common question I get, is my bunion one that needs to be fixed, or should I get my bunion fixed? And I ask them, is your bunion affecting your quality of life? And I look at two things. Is the bunion causing you pain? And has the bunion caused you to make alterations in your lifestyle? Meaning, are you no longer able to wear shoes you used to wear comfortably? Do you no longer do activities that you enjoyed doing or used to do because you know that your bunion will hurt after a while? And in my opinion, if those are things that you can say yes to, then absolutely it's medically indicated. Here's another scenario that is unique also. There are instances which make me scratch my head where a person comes in and, I mean, they look like they have had a golf ball surgically inserted under their skin and their toes are crossed, and they'll say it really doesn't hurt very bad, but they're constantly getting irritation and skin breakdown, and they really can't find shoes anymore. I've literally had people come in the office where they start cutting holes in the inside of their shoes so the bump can stick out. In my mind, that's medically necessary because at some point I believe it will start hurting, and maybe even more importantly, if you develop a wound over that, the risk of infections and problems with that increase. So those are some of the things that I look at to determine if a bunionectomy or a Lapiplasty is medically necessary.
If someone has bone spurs on the top of the feet, would the Lapiplasty procedure help that as well?
It depends on where the bone spurs are. If the bone spurs are at the midfoot, at the joint that's unstable and causing the bunion, then yes, when you fuse that joint, you actually will be addressing some of the force and the spurs that are there. If the bone spurs are in other parts of the foot, what the Lapiplasty will do is it will restore normal function and alignment, at least in the great toe joint. And it's not uncommon that other parts of the foot feel better and benefit, but I wouldn't go as far as to say that those bone spurs will go away or anything of that nature. You just might notice other parts of your foot that were bothering you aren't bothering you anymore simply by restoring the normal biomechanical function of the foot with the Lapiplasty.
Okay. There's someone who is considering the Nova Step surgery. Are you familiar with that, and how would you contrast that with the Lapiplasty procedure?
Can you say that procedure again?
It's called the Nova Step surgery. I'm not sure if that's something you're familiar with.
I'm not familiar with that. I wonder if it's that slide I showed where there's just a cut, almost percutaneous, and the bone is shifted over. But I'm unfortunately I'm not familiar with that particular procedure.
Okay. Back to arthritis. In the case of arthritis in my toe, what should be done first? Surgery to remove the arthritis, and then the Lapiplasty procedure?
It's a lot to do with the extent of the arthritis. If you have a significant amount of arthritis in the joint, as we talked about earlier, you need to have a conversation with your doctor about whether a Lapiplasty is the best procedure for you. But if it's arthritis that's, I would say, mild to low moderate, and it's clearly a result of the alignment of the joint because of the bunion, then that would be addressed by realigning the joint. But I don't think I would ever recommend somebody go have a cleanup procedure and then come back and have the Lapiplasty. If it's that much arthritis, you should probably address the problem there with a more appropriate arthritis type procedure than the Lapiplasty.
All right. Now this would be a tough question for you to answer, but how much pain should someone expect after surgery, or is numbness and tingling normal?
That's a good. I can't talk about what other doctors' experiences are, but I can talk about what my patients experience and how I handle their pain. At the end of my procedure, I do a block, a local anesthetic block, that most of my patients tell me. I do surgeries mostly on Fridays, and most of my patients tell me that block lasts them through the weekend or most of the weekend. And meaning they have little or no pain those first few days. I tell them that's good and bad. The good is they have little or no pain, and therefore they feel better. They're not having to take as much pain medication. The bad is when you don't hurt, you may have a tendency to do more than you should. When you're hurting, you're curled up in bed or on the couch telling everyone to get away from you because your foot hurts. And so I do a block that gives them those first several days of some significant relief, if not complete relief. And then after that, pain is appropriately managed and adequately managed with typically a hydrocodone type product with or without an anti-inflammatory in conjunction. Most of my patients are taking pain medicine regularly for maybe the first 3 or 4 days, and then they transition to Tylenol or ibuprofen or Advil or one of those over-the-counter anti-inflammatories, and then maybe take some pain medication at night if it's kind of aching and sore for maybe the next several days. Everybody is different, and everyone's pain threshold is different, but most people are pleasantly surprised at how minimal the discomfort is. It's surgery. It's still surgery, and you should expect to have some discomfort and pain, but it's
okay. Well, we're probably getting a little bit close to wrapping up here. There's a question about cutting the bone. Is the bone cut at all during the Lapiplasty procedure?
Yes, an osteotomy is performed, which is a fancy doctor word for the bone cut. Some doctors say I break the bone, and I don't like that term because it sounds so rough. But one of the unique things about the Lapiplasty system is the precision cuts. As we showed you in some of the slides, we correct the problem and we visualize it before any bone is cut. And then a precision cut guide is put in place so that these cuts are made true and they're minimal. We take the appropriate amount, but we don't take too much. But by removing the joint surfaces in the unstable joint, what we're doing is we're correcting the problem, but we're also getting those 2 pieces of bone where we made cuts to now mend and grow together. That's what gives you the stability. So yes, the bone is cut, but that's what's done to correct the deformity.
Okay, we'll have a couple more questions that have come in. Asking once again about a comparison to another type of surgery. Have you heard of a pro-step surgery, which is a minimally invasive type of surgery? Could you expound on how minimally invasive procedures might compare and contrast to the Lapiplasty procedure?
Again, I don't do minimally invasive bunion surgery, so it wouldn't be appropriate for me to comment on that. The thought process of minimal invasive surgery is not inappropriate, and I'm not saying for bunion surgery, just in general, as medicine looks at, are there ways for us to make corrections and fix problems, without exposing too much tissues? And so that thought process is reasonable and should be explored. But again, don't pick a procedure by the size of the incision. pick a procedure that has the best chance of correcting your problem now and giving you the best chance of correction, permanent correction in the future. So again, I'm aware of some of these minimal incision procedures. I do not perform them, so it's probably not appropriate for me to comment on them. But I know that they have hit the advertising and the waves hard recently as far as bunion and foot surgery is concerned.
Then we have another question about getting both feet done at one time. Is it possible to get both feet done at one time? And if not, how long would you wait in between?
Yeah, I think we had this question earlier too. We do not recommend, most surgeons do not recommend doing both feet at the same time. And I would say 8 weeks, 6 to 8 weeks is the minimum amount of time. I say 8 weeks because I want you to do 6 weeks in the boot and then be out of your boot for 2 weeks before I slap a boot on your other side. So if you have bunions that need to be surgically corrected on both feet, start looking at your calendar and try to plan at least 6 to 8 weeks in between the two surgeries. But again, that will be a decision that you and your surgeon make.
Okay, well, it looks like we've pretty much answered all the questions. If we didn't, I apologize, and we will make sure to reach out to you, or you can reach out to us if there is something inadvertently overlooked. You do have our contact information through the correspondences that we've sent you in regards to registering for this webinar, so feel free to shoot us an email. We're happy to facilitate getting any questions answered that you might have. Once again, you can also learn more and find a locally trained Lapiplasty doctor by visiting our patient website, which is www.alignmytoe.com. And our follow-up with you will be for us to email all the registrants an archived webinar for reference. So be on the lookout for that from us within the next couple days. And we hope you found the information presented tonight helpful in your decision-making process. We really appreciate you joining us, and we want you to have a good evening.